Now, next we will turn to the Associate Professor Hsiao Liang-Tsai, Director of Hematology at TVGH, who will be discussing the bone marrow transplant for complicated leukemia treatment, an advanced clinical solution for complex hematology malignancies. Let's give a warm welcome to Professor Hsiao.
Thank you. Bone marrow transplantation, or we call hematopoietic stem cell transplantation, HSCT, is one of the part of cancer treatment. Today, it's my honor to share our experience. I will try to illustrate our advance based on the case presentation. This is my outline. This one.
Yeah. Yeah, we should turn this way. This is for moving forward. This is, yeah.
Sorry. Up to now, there are more than 20 hospital center who perform the transplantation. The Taipei Veterans General Hospital began this treatment earlier, since in 1984, along with the National Taiwan University Hospital. Up to now, this established by my mentor, Professor Peng Chen. Since 1984, we have more than 3,000 cases. Earlier, we have only 4 Lun. It's really the number is very small. How we can perform the so many cases, because we needed to shorten the the time in the BMT Lun. From 2 years ago, we have 8 Lun. The Lun mainly for the allogeneic transplantation case. In general, about 50% case were allogeneic. At first, we used the bone marrow, but up to now, nearly 100% case receive the peripheral blood stem cell harvest. The donor origin, initially we used the matched sibling, then we moved to the unrelated donor, but right now, half of case, allogeneic case, use so-called haploidentical family. Yeah, the GvHD population is the policy. At the first, we used cyclophosphamide natural cause MTX. For the unrelated donor, we use add some ATG. But right now, we use post-transplant cyclophosphamide for haploidentical, also or unrelated donor. Some scientific achievement in our hospital in HSCT activity. We have published some important report regarding HPV infection in hematopoietic stem cell transplantation and patient with hematological malignancy. 2 years ago, we have a new building. Our superintendent, Professor Chen, held this the activity. Yeah, we have new Lun, BMT Lun. And recently, we in our hospital, we also begin the CAR-T therapy. Some of patients we consider may need to be admitted in this Lun with intensive care. Yeah, the left side is the Vietnam physician. He come to our hospital for the training. The left side is the Professor Kim, is a Korea doctor to visit our BMT Lun. So for the scientific activity, In 1998, Professor Chen published the increased incidence of familial hepatitis after transplantation for patients who are HPV surface antigen positive. Later, we shown the extent of lamivudine therapy can reduce the HPV reactivation. And as you know, those of the finding become the guideline. This is published by 10 years ago by hepatologist Professor Huang and our team. We found the lymphoma case with rituximab with reactivation in HBs antigen negative, so-called resolved hepatitis B. This is also is a guideline for every in this field. So for the advance of the HCT in the last decade, I try to separate the civil part. This is the first is the application of we call the reduced intensity condition. This begin in the end of 1919, and this is for the patient with who are elderly and who are heavy treated. They are fragile, cannot tolerate the intensive chemo condition regimen. The second is the prophylaxis of acute GvHD. I think in last 5 to 10 years, the post-cyclophosphamide is important to overcome the HLA barrier. And so, in addition, I think the infection, we have many antibiotic, antifungals, and at first we just use those drugs to control, but there are many topical to be used prophylactic. In addition, we also have improved supportive care. This is a simple schema is to clarify the difference of non-myeloablative condition and the myeloablative condition. The difference is the intensity and the cost pancytopenia and the need of two stem cell support. So at first we use the non-myeloablative condition regimen in contrast to the myeloablative. But many regimen become between these two sides we call the reduced intensity condition regimen. Yeah, this is another advance in, this is a PTCY, we call the post-transplant cyclophosphamide. The first dose is, it is strange to give the chemotherapy after stem cell transplantation, but this is the policy, why the policy can be successful, yeah. The post-transplant cyclophosphamide can eradicate the reactive immune cell, but cannot kill the stem cell. So in general, we use at the first conventional use per kilogram 50 milligram. But yeah, Japan physician to establish the 40 milligram. Yeah, recently just published 25. It's okay. It's okay. So I briefly show this case. This case right now is 76 years old. 76 years old. He has hypertension, hyperlipidemia. Last year he just received spine surgery. It's similar to many elderly population. Yeah, the hematological disease was presented in the end of last year because he has a fever, bone pain. So she was admitted to our general medicine ward. But because the pancytopenia, they consult the hematologist. Unfortunately, she was diagnosed acute leukemia, AML. is a similar condition. He has a poor prognosis, feature myelodysplastia, and according to the ELN risk group, and he has adverse risk group. So we can expect he has overall survival maybe less than 10 months. We begin the remission induction. We think through in last few years we have BCL2 inhibitor venetoclax. We plus the azacitidine. The patient finally achieve a complete remission after 3 cycle therapy. What's the next treatment? Because she is very old. Yeah, we just continue the treatment. Oh, do we want to perform the allogeneic transplantation? Before I present the further step, I briefly show more than 20% of Taiwan population will be aged, so we call super aged society. So Taiwan aging rate is among the fastest in the world compared to Japan, Italy, and Germany. There are 3 reasons: declining fertility, increased life expectancy, delayed marriage, and childbearing. So for our allogeneic transplantation, the recipient become older, we can find a match the donor. So for this case, this is Taiwan. This is Taiwan life experience. In Taiwan, the life experience is over 80 years. And for the population in the main city like Taipei City and the new Taipei City, you can find the female has a life experience nearly 86 years, like this patient. And the family member actively contacted me, asked to, can we perform allogeneic transplantation? Yeah, she has 4 children. The youngest children was 45 years and a male. Finally, we choose this the child for the donor. So we performed the transplant in last month. The cell dose was really good, and fortunately, the patient did not have severe infection, and the neutrophil count about 500 on the day 12. The neutrophil about 20,000 about day 10. On the day 14, his blood confirmed to be the donor type. Right now, he will be discharged. So we can find the platelet count. Yeah, this patient. The other side. This is his daughter, her daughter. We ask her for the elderly patient. We need to a caregiver even in the BMT room. And during the stay, the BMT room, we encourage the patient to exercise. We know many elderly patients when be admitted the muscle will weakness. So this is international data. We can find up to now maybe 10% of the allogeneic transplant will be had age more than 70. For the age more than 75. Right now, it's still less than 1%. Yeah, so it's we have needed many evaluation, resistance side and stress side. We needed to consider the patient physiological aging ecosystem. The stress side, we needed to consider the disease, the status, and the transplantation parameter. Yeah, this is just, you can find, we needed to do a lot of work before we decide to perform the transplantation in this patient. Yeah, this is another interesting patient. This patient was diagnosed, received the living donor liver transplantation at age 65. 2 years later, he developed AML. Yeah, so the first, do we want to give chemotherapy in this patient? That's a difficult question. Unfortunately, we give the induction chemo, the disease remission, but the relapse later. So we needed to give a reinduction. So we may need to give the allogeneic stem cell transplantation. What is the source of the stem cell transplantation? Finally, the patient, we use the same donor, liver donor. We use the stem cell from the same, his daughter. Unfortunately, the harvest amount of the stem cell is not so enough. So after the stem cell transplantation, we also aspirated bone marrow about 100 milliliter. The transplantation is successful, and right now he continues to follow up. So this patient received the liver and the stem cell, and including the bone marrow. I illustrated another scenario is collateral, or we say second degree relative donor. This is a 45 years male. He has a poor risk acute myeloid leukemia. His disease cannot remit. So how we can do? Of course, we try to consider allogeneic transplantation. How about the donor? He is single. And the only young brother is not a match. And the mother has breast cancer. So, and also he matched the unrelated donor. So he contacted his the only uncle, and the uncle daughter is cousin. Finally, we choose the cousin for his stem cell donor. The cousin is 32 years old. So the transplant is successful. Right now, his disease is remitted. And no evident acute GvHD. Yeah, so this is simply recently meta-analysis from China. I did not mention in detail, but you can find if you for happily identical family member, even you use the first degree family, but sometimes you can try to collateral or with non-first degree. The outcome is similar. Finally, I will show some case. We use the HSCT for at our International Medical Service Center. And here I show 5 cases. The first case is 4 years ago. The second case, so from the last 2 months, the different age. For one patient come from Indonesia, the other 4 from the Vietnam, except for the last one case with severe plastic anemia. The other 4 cases are acute leukemia, with most of them has advanced stage. The TAL case has relapsed refractory. I will mention it. All the cases receive haploidentical from the donor, from the daughter, sister, and the father, and the son. Except for the third case, he has a successful transplant, but unfortunately relapsed 1 year later. Yeah, so summary, my challenge is the COVID pandemic in early years, like the quantity for the patient, donor, and family member. And we have a limited time of stay in Taiwan, including the financial issue. I think one of the most important is the communication. Maybe the patient can communicate with me in English, but unfortunately, if the patient on critical condition, he can communicate with me. Unfortunately, sometimes their family cannot communicate with me in English. In addition, we always reevaluate the disease when arrive to Taiwan. So this is a case. This is TAL case. When I received the reverse sheet, is indicate complete remission, but when I see the patient, we found, this is a refractory. We also found a rare mutation. And for this case has a severe so the question is the patient will continue to receive the reinduction or back to Vietnam. Finally, the discussion, they decide to stay in Taiwan to receive the reinduction. Unfortunately, she developed severe septic shock, but fortunately, he escaped this accident and then received haploidentical. So this I just show you. This mutation is rather rare. It's very rare and has a poor prognosis. So we also has customized to develop some real-time quantitative PCR to monitor his minimal residual disease. So I show the last one case. This case is just arrived in this May. Is severe aplastic anemia. So we need 1 month to discuss, to evaluate this, to treatment, because the guidelines suggest immune suppression. If they decide to use Allogeneic, which is the donor, is the match. He has a match sister, is over 50 years old, but he has haploidentical son. Finally, we choose he should choose the son for the donor, and 1 month later we collect the stem cell. Less than 2 months, we finish the haploidentical, and about at the day 81, she was discharged. You can find the hemoglobin improvement, platelet count improvement. Yeah, the left side is Indonesia patient has annual outpatient visit. The right side is the SA patient. Yeah, his hemoglobin is improved. Yeah, so I think, as I mentioned, we have performed more than 300 cases. Right now, we also perform CAR-T therapy to extend our care of hematopoietic stem, hematomalignant case. I think with the referral of our International Medical Service Center, our division, our TCT unit will continue to provide timely and in-depth medical service to foreigners. Thank you is my talk, and thanks to our hospital support.